everyone, my name is Leonardo Faundes. Thank you so much for watching this video on intercostal scanning of the right upper quadrant. I remember in my time teaching ultrasound, many students had a lot of resistance and they were very intimidated when we were teaching them how to scan intercostally. And I understand that because all of a sudden now you're seeing the anatomy that you used to see subcostally but from a different point of view. It's like if instead of looking at me front face, right, you were looking at me from this angle. So initially, it would take some time to get used to where is the right eye, where is the nose, and where is the right ear. But with time, you get used to that. I used to tell my students that it was like peeking through a fence, through the spaces of the fence. And I'm pretty sure some of them would feel like this. Or they would feel like this. Another point that they would used to bring up was that they would feel afraid of hurting the patient because now they were putting the probe on the rib, and we all know that it could be a sensitive area. But there are ways to overcome that, in that, for example, instead of applying all the pressure that you're going to apply, start very light until you are actually certain that the probe is parallel to the intercostal spaces, and I'll explain more about that in a few minutes. And so once the probe is aligned and in the intercostal space, then you can press a little more and it won't hurt as much. And of course, you always communicate with the patient and you ask them to let you know if anything that you're doing in terms of pressure is hurting. Intercostal scanning is a very good complementary window or approach to subcostal. By no means I'm saying that intercostal scanning replaces subcostal approach. No, it's complementary. And many times it has happened to me, and I'm sure that it has happened to those of you who are currently using intercostal scanning for the right upper quadrant, that you only get to see a lesion in the liver, for example, if your approach is intercostal. No matter how much you try subcostally, it's not possible to see. And so that's why I strongly recommend to always look intercostally, even if you can see really nicely subcostally. Doesn't matter the visibility of the patient. Always spend some time, a few minutes, looking at the intercostal or looking at the right upper quadrant through the intercostal spaces. And I know some of you may be thinking, well, this is going to add a lot of time, and I have a limited time to scan per patient. But perhaps initially will take long. Remember your times when we were learning ultrasound, it took a lot longer than now. And so with practice, you'll see the difference. And then when you feel very comfortable about intercostal scanning, you're only adding a few seconds really when investigating the right upper quadrant. All this information that I'm going to be talking about in this video is definitely applicable to adult scanning. Perhaps some of them are also applicable to pediatric, but my experience is mainly on adults. I'm going to use this prop to represent the rib cage on the right side. Okay, and so intercostal scanning is very useful in cases when, for example, the rib cage is quite long on someone, right? Or if the liver is quite high under the rib cage, and so subcostally is not, it's a very limited option. And other times, as I'm sure you know, if this represents the colon, you may have seen that the hepatic flexure can be quite in the way subcostally. So if we come subcostally, we're going to have to go through the colon, through the hepatic flexure, in order to get to the liver. And we can try turning the patient, of course, to try and see if this hepatic flexure follows gravity and falls, falls down. But sometimes it's impossible. And so, two reasons why to try the intercostal scanning here. Number one, you don't want to get frustrating going subcostally through all that gas, through all that air. And number two, do you really want to keep pushing on all that gas in an enclosed environment? Let's talk about technique. So, as I mentioned, as I showed you before, if this is a right rib cage, we can see that the intercostal spaces are diagonal. Okay, so that poses a little bit of a challenge if we are so used to scanning either in true sagittal or true transverse, right? And so something to consider here is you can place a probe along the midclavicular line or lateral to the midclavicular line on the right side and have the top of the probe rotate so that rotate the probe so that the top of the probe is pointing to the right axilla or the right shoulder as a starting point. And then you can always fine-tune the rotation so that you are aligned, so the probe is aligned to the intercostal space. Another approach could be that you place the probe in true sagittal and then you start rotating the probe until you actually get to see that you are aligned with the intercostal spaces. And so how do you know that? Well, all of a sudden, if you are aligned to the intercostal space, you're going to see an image like this. So no shadows, right? Or you may see a little bit of loss of contact at the edges of the probe, depending on how curved that surface is compared to the transducer. If you happen to be rotating the probe and you are on top of a rib, then you're going to see this. So the shadow of the rib covers most, if not all, of the field of view, and you don't see anything. So actually, those are good news, because that means all you have to do is just slide towards the intercostal space, whether it's the one inferior or superior. Now, if you're not parallel to the intercostal spaces, and let's say you're somewhere between sagittal and and the angle to be aligned, or the rotation to be aligned, and you're sort of like this in between, then you're going to see this. That is, you're going to see the shadows of the ribs as circles or oval shaped areas. The other thing I would like to bring to your attention to is that once you are aligned, once the probe is in one of the intercostal spaces, then what you're going to do is you're going to be sweeping or sweeping side to side. So in this case, it will be from shadow to shadow, from one rib shadow to the next rib shadow. And then you're going to slide without rotating the probe to the next intercostal space and repeat the same. As you move down or up to the adjacent intercostal spaces, you may have to do some fine-tuning on the rotation because of the fact that they're curved. Another important thing here is that the intercostal spaces are long. Obviously, I have this edge here that doesn't really represent the true nature of the intercostal space, that it will continue towards the back, but you get the idea. So the thing is, make use of the entire length of that window of the intercostal space. So if you are here at this end, you can always slide well in the intercostal space and then see what else you can see from that approach. In my experience, I would say, and it varies with patient to patient, but you will have about 3 to 4 intercostal spaces that are quite usable. In addition to the technique on the probe, you can try different breathing techniques, right? Small, medium, large breath, just holding the breath on command, or quiet breathing, and changing the patient position, supine, decubitus, in between, even standing up. And so by doing all of that, you're adding more to the repertoire of using the intercostal windows. As I said before, you're probably thinking, wow, that's going to add a lot of time. But again, you're not going to probably using all of those techniques at the same time. And you'll get to learn when to use it, when to use some of them, or which ones are more applicable depending on the patient's body habitus and, of course, the visibility. Something else to mention about the technique is that anchoring your scanning hand. As I mentioned before, you're scanning a curved surface and you're using a curved probe, so it will be very slippery, plus the gel, of course, right? So what you want to do is that if you're a sonographer that uses 3 fingers to hold the probe, you can use these 2 to anchor or to be on the skin, on the patient's skin, so that will give you more anchoring surface. If you like to hold the probe with all your fingers, then you can use the side of your hand to rest on the patient's skin, and that way you have more control. It helps a lot, especially at the beginning, novice sonographers and students. It helps a lot to have that anchoring, and it's a good habit to get into that from the beginning. And you can obviously apply that anchoring everywhere in the body, whatever part you're scanning, but I find that for intercostal scanning, it's even more important. So there are several structures and organs that we can see through intercostal scanning that are present in the right upper quadrant. The first one I want to show you is, of course, the gallbladder neck. I find that if I place the probe at the mid-clavicular line, more or less, and then try to find sort of, I go from the costal margin and find the first intercostal space, and I can be in sagittal. I don't have to be rotated, where I can be, it doesn't matter. There is a tendency to find that you're gonna get to see the gallbladder neck. This is, by the way, gallbladder I want to use for this explanation. So you get to see the neck of the gallbladder in the area of the cystic duct. This is very useful. I have found it very useful in those patients where you need to rule out acute cholecystitis. So they're very tender subcostally, and you try and push, and but sometimes they don't let you, or the visibility is really bad. Try looking at the gallbladder neck through the intercostal spaces, and if there is an impacted stone, then you found it, right? By the same token, from the same area or adjacent intercostal spaces, you get to look at the periportal region, which means you're going to be able to see the main portal vein, the common hepatic duct. You may even see the proximal common bile duct, depending on how high or low the joining of the cystic duct and the CHD is. And you can look for nodes as well in the periportal region. By the way, I'm not just talking about acute cholecystitis cases here. This is applicable to all cases. Something else, of course, and this is probably the most obvious one, is that you'll get to see areas of the liver that are far away from a subcostal approach. So if this is the liver I want to use for this explanation, you see that segment 7 and segment 8 they are so close to the diaphragm, so the dome. If you come from the subcostal approach, you're going to be very far away from those. But if you come intercostally, you're extremely close. You're right there. And so again, you're going to try different intercostal spaces to look at that region. Once again, I want to emphasize, intercostal scanning, it's not perfect, right? It's quite limited. That's why I've been saying that it is complementary to subcostal approaching, to the subcostal scanning, okay? So by doing this and then using these, you're taking a better look at the structures in the right upper quadrant. Remember that ultrasound is angle dependent, not in just Doppler, but also in 2D. So the more angles that you use to look at a specific area of the body, the better. You increase the chances of seeing something that is actually there. Going back to the periportal area that we can see intercostally, another structure that we can take a peek at is the duodenum. And sometimes I have even been able to see the superior aspect of the pancreatic head. But again, it depends on visibility. Another structure that we can see intercostally, I'm going to use this to represent the 3 hepatic veins. Okay, so right, middle, and left. So if we use let me move this a little closer this way, there we go. If we use now a more lateral approach, the lateral aspect of the intercostal windows, of the intercostal spaces, and sort of we aim medially, look at the angle that we're going to be getting the right hepatic vein at, almost at 0, right? Compared to subcostally, that we're almost getting it at 90 degrees, right? So from a Doppler point of view, that's not good. Even sometimes the middle hepatic vein can be at a good angle if we come from the side. And speaking of vessels, another vessel that is also useful to see would be, if this is my main portal vein, the right and the left portal vein, you can see here that the right portal vein will also be at a really good angle from a Doppler point of view, so almost 0. Again, very easy to get it and much more accurate than trying to get it subcostally. Okay. Something else, now that we're speaking about the lateral aspect of the intercostal spaces, if we go a little more inferior, we're going to get to see Morrison's pouch and right kidney. So I'm going to use this to show the kidney. Depending on how high or low the kidney is, sometimes if the kidney is low, obviously that's not going to help. But you'll see that, I'm sure you have seen that intercostally, you at least can see the upper pole of the kidney, of the right kidney that is, and the Morrison's pouch. So also very useful. And then in addition to that, something else I didn't mention before, if we go back to the liver, if the liver is too high, as I had mentioned before, or the rib cage is too long, intercostal approach to scanning may help you see that inferior surface. If you're looking for nodular contour of the liver for cases of cirrhosis, for example, and you can't see the inferior edge subcostally, that's another approach. Same thing up here, you can see the surface of the liver intercostally, right, of the right lobe, by having the probe pretty much right on the liver, and you can look at that surface of the right lobe. You can use a higher frequency probe, curvilinear, or you can even use a linear probe if you're again looking for that surface nodularity in the liver. Something else that another area that you can look at, if we now go back to the more superior intercostal spaces, but more laterally, you get to see the diaphragm, right? And if you're looking for a right pleural effusion, that's a spot. Same thing if you're looking for any fluid around the dome of the liver, that would also help. So again, I know that I've been saying this a lot, but intercostal scanning is complementary to the subcostal approach to scanning. I'm not saying that intercostal scanning will replaces it subcostally, but sometimes that's the only option that we have, and although limited, it's still better than nothing. But I think the great combination is subcostal and then intercostal. So I highly recommend that you always use intercostal whenever you're scanning an abdomen, whenever you're looking at all those structures that I mentioned already. I hope that after watching this video, and if you haven't been using intercostal scanning, you look at it in a better way, that it's not as intimidating. And I really hope that the way that you will look at intercostal scanning now is like this. And you get to practice it more. And when you come out of that room and you go and check your images and you see your beautiful intercostal images, you say to yourself, yeah, I took that picture. I'm an intercostal fan now. After watching that video from that Leonardo guy, piece of cake.